Thank you for your kind introduction. Good afternoon, everyone. Okay. HIV is able to move across the blood-brain barrier in order to reach the central nervous system. And here it could lead to neuroinflammation and consequently and probably to neurological disorders, even though the antiretroviral treatment efficiently suppresses the viral replication. HIV-related neurological disorders mechanisms have not been clarified yet, but in the literature, two different hypotheses could suggest us which could be the causes of neurological disorders. So one suggests that it could be due to antiretroviral drug toxicity, whereas the other one suggests us that it could be related to a poor antiretroviral treatment, CNS penetration through the blood-brain barrier. As you know, the blood-brain barrier is able to regulate the movement of toxic molecules, including drugs, but also other molecules. For example, the amyloid beta, which is a neuroinflammation biomarker usually used in the Alzheimer's disease. And drugs, but also amyloid beta and other molecules, as you know, are transported by ABC transporters across the blood-brain barrier. Some ABC transporters are, I can try, if Paolo Denti can, I can, no. I cannot. So some ABC transporters are the P-glycoprotein, which is encoded by the ABCB1 gene, MRP2, which is encoded by the ABCC2 gene, and ABCG2, which is encoded by the same gene. In fact, in the last few years, various studies have focused on the potential role of ABC transporters in the pathogenesis of the Alzheimer's disease. And particularly, we can see that a deficiency in P-glycoprotein could be associated with an increase in amyloid beta deposition in an Alzheimer's disease model in mice. And as you know, deficiency could be related to genetics. So genetic polymorphisms could impact on drugs penetration, but also on neuroinflammation biomarkers and probably on neurocognitive disorders. But currently, no data are available in the literature concerning people living with HIV. Thus, the aim of our study was to evaluate if some ABC transporter genetic polymorphisms are able to impact on drugs concentrations and on neuroinflammation biomarker levels, such as the total tau protein, its phosphorylated form, so the phosphotau, amyloid beta 142, and neopterin. So, people living with HIV who underwent a lumbar puncture for other clinical reasons were enrolled, and they were divided into 5 different clinical groups according to their neurological symptoms. So we have participants without neurological symptoms, HIV-unrelated neurological complaints, so for example, the psychiatric disorders, HIV-associated neurocognitive disorders, so the hand, other HIV-related CNS disorders, so for example, the HIV encephalitis, and finally, HIV-unrelated CNS disorders as cancer. So, neuroinflammation biomarkers were evaluated in the CSF, so the cerebrospinal fluid, through immunoenzymatic tests, whereas drugs were measured both in plasma and the CSF through liquid chromatography. And finally, single nucleotide polymorphisms in ABCB1, ABCC2, and ABCG2 genes were evaluated through real-time PCR. The characteristics of the 163 analyzed samples are here reported, and as you can see here, in the last part, you can see the different percentage of the 5 different clinical groups. Here we can see that the polymorphism ABCB12677 has a different allelic distribution according to the clinical group. So for example, we can see on the right that the G genotype is more frequent in neuroasymptomatic participants, whereas the GTTT genotype is more frequent, on the left, in HIV and related CNS disorders. In addition, here in this table, we can see that genetic variants obviously could have an impact on drugs concentration, both in CSF and plasma. Here we can see the different administered drugs according to the clinical groups. So, for example, we can see that neurosymptomatic participants usually use protease inhibitors. And in addition, we can see that higher amyloid beta 142 levels were higher in patients administer integrase inhibitors, as you can see on the right. Finally, we evaluated which demographic, pharmacological, clinical, virological, and genetic factors were able to predict the neuroinflammation biomarkers through through a regression analysis. And here we can see concerning the total tau protein that age, CSF proteins, and integrase inhibitors are predictors of total tau proteins, whereas the phosphorylated tau protein were predicted by gender, CSF proteins, and ABCB126. Sorry, but the animation is different. So, as you can see in the figure, phosphotau protein is predicted by the ABCB12677 genetic polymorphism, and particularly GTTT genotype participants have higher phosphorylated tau protein compared to GG genotype participants. For the amyloid beta 142, predictors were protease inhibitors administration, neopterin, and also in this case the ABCB12677 genetic variant, and finally neopterin. So many factors, including the genetic polymorphism, the ABCD2, as reported here. So, in conclusion, this is the first study showing a potential involvement of genetics in predicting, obviously, drugs concentration, but also neuroinflammation biomarkers levels. But these data have to be confirmed in different and larger cohorts of patients in further studies. Just to conclude, which could be the clinical potential scenario for this data, because I know my clinicians, so they want to know which is the impact of genetic information. So, for example, it could be useful to analyze the genetic polymorphism, in this case ABCB12677, before starting therapy, and according to the genotype, but obviously the kind of treatment. For example, for GG genotype, we can routine monitoring as usual, whereas, as suggested for GTTT genotype participants, we could accurately manage these patients, and so, for example, with frequent TDM or an intensive clinical monitoring. So, but this is a work in progress, so we have to wait further studies. So, I would like to thank the organizers, all my colleagues, and all of you for your attention.